Hello everyone, my name is Ashley Watterson and the title of my DMP project is Screening Adults for Depression in Primary Care, a Quality Improvement Initiative. Thank you for watching. The committee members for my project consist of Dr. Jennifer Brunworth, who is my scholarly project chairperson, and Dr. Sharif Kaiser, who is my community committee member. This slide depicts some basic background knowledge on depression. It is the most prevalent mental health disorder in the United States and abroad, and it is the leading cause for disability within the U.S. Unfortunately, despite its perceived prevalence, it remains grossly underdiagnosed and undertreated. Therefore, screening for depression in the primary care setting is imperative to ensure completeness of care. The image on the right-hand side of the slide is something that speaks volumes to me. The image on the upper half portion of that photo shows a woman who's in clear distress. Unfortunately, this is not the typical presentation of a patient who comes to an office with depressive symptoms. They typically appear as Robin Williams does in the bottom half of the photo, where they have a smile on their face, they're cordial, they're communicative, they answer questions appropriately. So this only further exemplifies the need for depressive screenings to be performed in order to capture patients who do not present as though they have depression. Depression is defined as changes in mood and/or cognition, decreased functionality, and increased physical symptoms lasting at least 2 weeks. Depression affects between 5 to 10% of adults annually, and approximately 16% of adults experience depressive symptoms at least once over the course of their lives. The cost burden associated with depression is estimated to be about $210.5 billion per year. And in fact, for every dollar spent treating depression, an additional $4.70 is spent to treat other conditions including anxiety, PTSD, sleep disorders, and even somatic symptoms such as chronic pain and migraines. Unfortunately, poor symptom recognition, particularly in the primary care setting, remains a major obstacle. In fact, 50% of patients evaluated in the primary care setting are not even recognized as having depression, and only 1 in every 5 patients with a confirmed diagnosis and treatment plan initiated report remission of their symptoms. And because of this, depression screenings must be conducted in order to detect symptoms in their earliest stages in order to stave off the consequences of untreated depression, which include increased chronic health conditions, destructive behaviors, self-harm, and suicidality. Performing depression screenings in the primary care setting are fully supported by the United States Preventative Services Task Force and the American Academy of Family Physicians, because this can reduce the risk of hospitalizations and the overall depressive symptoms through early recognition and diagnosis. And one method of screenings is through the use of the patient health questionnaires, which are brief self-administered depression screening tools and are the most widely used tools in the primary care setting due to their ease of use and accuracy. The PHQs have been extensively researched worldwide and have proven validity and reliability. They are also readily available for instant download without copyright restrictions and at no cost to facilities. By utilizing the PHQs, patients can be quickly and accurately screened for depression and treatment plans initiated based on the severity of reported depressive symptoms. This slide depicts the patient health questionnaires that were administered to patients throughout the course of this project. Both questionnaires ask specifically about symptoms experienced over the preceding 2 weeks. On the left-hand side of the slide is the Patient Health Questionnaire 2, which is used as an initial screening tool. And for the purposes of this project, if the patient scored a 3 or higher on the PHQ-2, they were administered the PHQ-9, which is on the right-hand side of the slide, in order to further evaluate reported depressive symptoms. And at the completion of the PHQ-9, the provider would tally up the scores to determine the most appropriate diagnosis and treatment plans based on the reported depressive symptoms. These are the PHQ-9 interpretation guidelines, and these guidelines were developed by a team of physicians in 2001 and have been extensively researched worldwide with proven reliability and validity. And these guidelines were utilized by every provider at this facility throughout the duration of this project. They would use the PHQ-9 scores in order to determine the most appropriate diagnosis and treatment regimen based on the reported depressive symptoms. This scholarly project set out to develop an answer to the following PICO question. For patients ages 18 to 89 years old who presented for routine primary care office visits and were diagnosis and treatment naive, would the use of the 2-step patient health questionnaire depression screening protocol when compared to not using a standardized screening method improve recognition of depressive symptoms and increase the percentages of patients diagnosed and the frequency of treatments initiated? The purpose of this project was to perform depression screenings on all adult patients ages 18 to 89 years old who presented for routine office visits and were depression diagnosis and treatment naive, and to utilize the two-step patient health questionnaire depression screening protocol to accomplish this. There were three primary aims established at the onset of this project. The first was to permanently standardize the use of this depression screening protocol. The second was to screen at least 25% of the adult patients who presented and met these criteria, and to surpass the national depression screening average in the primary care setting, which is 4.2%. Prior to the implementation of this project, I conducted an extensive literature review, and this review identified three primary themes. The first being that there are sociodemographic risk factors associated with the onset of depression. Gender, race, and income tend to be the three most prevalent risk factors associated with the onset of depression. Women are about twice as likely as men to develop depression. Hispanics, African Americans, and whites respectively report depressive symptoms the majority of the time, and those that are either at or below the poverty line are considered the highest risk. The next theme is that there are patient-centered barriers to depression screenings. The first being that patients often will refuse or fail to complete the PHQs. And then the other theme is that many patients that have a limited education or reduced mental capacity have a higher prevalence of depression. And lastly, there are system-related barriers to depression screenings. First, geographical locations, primarily those that are in very rural or very urban areas, and also those that have limited access to healthcare providers within their surrounding communities. There were also clinical practice implications that were illuminated throughout the literature review. First, the vast majority of the available literature indicated that the use of the PHQs via the two-step process was superior to simply using the PHQ-9 as a solo screening tool. And the second theme is that the use of the most appropriate cutoff scores must be utilized. So for the purposes of this project, the cutoff score for the PHQ-2 was a score of 3, and this indicated the need for the PHQ-9 to be administered. And all of the providers that participated with this project determined that the score of 9 for the PHQ-9 would be the cutoff. And that's because this score, the score of 9, can easily differentiate between dysthymia versus major depressive disorder. And both of these scores, so the 3 and the 9, had the highest and most balanced sensitivity and specificity while also limiting the number of false positives. This project was conducted at a privately owned primary care facility in the eastern region of the United States where no prior depression screening protocol was in place. We utilized the two-step PHQ depression screening protocol where the PHQ-2 is administered as an initial screening, and then if the patient scored a 3 or higher, the PHQ-9 was then administered. The design for this project was a quantitative and exploratory design, and data was collected via a retrospective chart analysis. The participants were all adults ages 18 to 89 years old who were evaluated for routine appointments during the implementation period, and I made every attempt to include equal distributions of age, race, socioeconomic status, and gender. And a list of patients that were seen during the implementation period was provided by the practice administrator, and data was collected via convenient sampling. This is the data collection tool I developed specifically for this project. All of the data that was gathered was collected from the EMR system currently in use at this facility. The EMRs were assigned a number, and all identifiable information was removed prior to it being uploaded to this tool. Each of the included variables were nominal, and they were coded according to the coding system so that they could be placed into SPSS for analysis. And at the conclusion of the implementation period, the practice administrator provided me with a list of patient names that were seen during the implementation period. And throughout the retrospective chart analysis, all of the data was uploaded to this data collection tool, which was saved to a password-protected Excel spreadsheet and saved onto a password-protected thumb drive. Both the patient list and the thumb drive were stored in my locked desk inside of my locked office at this facility, and only I had access to the office key, desk key, and passwords needed in order to access this information. This is a list of the inclusion criteria I used throughout the retrospective chart analysis. The participants had to be between the ages of 18 to 89 years old with no prior diagnosis or treatment plans for depression. The EMR also had to show that the patient was seen for a routine office visit only. The EMR had to contain documentation that a PHQ-2 was administered, and if positively screened with the PHQ-2, the EMR had to also contain documentation that the PHQ-9 was administered. They also had to have documentation that the depression screening was billed for appropriately. And lastly, the EMR had to contain documentation that if the PHQ-9 showed a positive screening, that the provider also documented the appropriate diagnosis and treatment plan. And this is a list of the exclusion criteria I also used throughout the retrospective chart analysis. If the patients were 17 years of age or younger, 90 years of age or older, they were immediately excluded. If the EMR had documentation that the patient either refused or failed to complete the PHQs, these were not included. If the patient was illiterate or could not independently answer questions or comprehend the questions being asked, they were not included. If they did not speak English or required a translator, these were not included. And any patients that were scheduled for acute visits, such as for injury or illness or telehealth visits, these were also not included. And lastly, every participant could only be included once, regardless of the number of times that they were seen throughout the implementation period. So if I already included this EMR one time, that was all that they could be added. This project was implemented over a 4-week time frame between May 29th through June 25th, 2022. The implementation period was designated as June 12th through June 25th. And the preceding 2 weeks, so from May 29th through June 11th, was identified as the pre-implementation time frame. So on June 12th of 2022, the practice administrator ran a report within the EMR that included the number of all adult patients 18 to 89 years old who were seen between May 29th and June 11th. No patient identifiable information was included on this EMR report, as this was strictly used to establish the pre-implementation depression screening percentage at this facility. This slide depicts the pre-implementation depression screening percentage. There were a total of 328 adult patients evaluated during the pre-implementation time frame, and only 13 of those charts included documentation of a prior depression screening having been performed. This report demonstrated an exceedingly low percentage rate of only 3.9%, which was also below the national average of 4.2%. On June 26, 2022, the practice administrator provided me with another EMR report that included the number of patients 18 to 89 years old who presented for routine appointments between June 12th and June 25th that were also screened using this two-step protocol. And this report was used to determine the post-implementation percentage. There was a total of 365 adult patients evaluated during this implementation period, and I'm very proud to say that 183 charts included documentation of depression screenings using this two-step protocol. So this report demonstrated a significant improvement in the percentage of depression screenings performed as the rate increased from 3.9% during the pre-implementation timeframe to 50.1%. This slide depicts the comparison of the intervention percentages to the national average and project goal. So as you can see, the pre-intervention percentage of 3.9% did not surpass the national average of 4.2%. However, the post-intervention percentage of 50.1% surpassed both the national average of 4.2% and the project goal of 25%. Therefore, this project was successful at implementing the use of the two-step patient health questionnaire depression screening protocol at this facility. Data for this quality improvement project was analyzed using an upper tail z-test for the proportion with an effect size of 0.05. And this test was selected due to its effectiveness at determining whether two population means are different when the variances are known and when the sample size is greater than 30 subjects. This data was analyzed with a power of 0.8 in order to achieve the statistical significance. The data analysis demonstrated that this evidence-based practice change made a statistically significant improvement in the depression screenings performed. And as you can see, the z-test statistic was 11.0907 and the p-value was 0.0000. Because the p-value was less than the significance level of 0.05, there was sufficient evidence to suggest that the ratio was greater than the national average of 4.2%. The achieved power of the study was 1.0000, which was considered strong. Therefore, I rejected the null hypothesis. After completing my initial analysis using the upper tail z-test for the proportion, I conducted some additional comparative analyses of the gathered data. First, I performed a breakdown of the number of patients evaluated by every provider in order to determine the percentage of screenings performed by each individual provider, and that is what is depicted on this slide. I did this mainly to determine if any provider required additional assistance with documentation or found this protocol difficult to employ in routine practice. All of the providers evaluated and screened approximately 50% of the patients they saw during the implementation period. So we were all very much equal on our abilities to see and screen these patients that were on our schedules. Next, I established the percentages of patients who received a new diagnosis of depression based on their PHQ-9 scores. And as you can see, over half of the screened patients did not receive a new diagnosis of depression based on their PHQ-9 results. The remaining patients received new diagnoses of depression ranging from minor depression, which was the most frequently used diagnosis, to moderately severe depression. These diagnoses were based on the PHQ-9 interpretation guidelines that were shown previously on slide 7. 0 patients were diagnosed with severe major depressive disorder, therefore this diagnosis was excluded from this figure. Lastly, I assessed the treatment options recommended by the evaluating providers, and that is what this slide depicts. These treatment recommendations were also based on the PHQ-9 interpretation guidelines shown previously. Now, as you can see, the vast majority of patients did not require specific treatment. However, the patients that did require an intervention received treatment recommendations ranging from simple support and symptom monitoring to a combination of treatment options, which, as you can see, is the most frequently used treatment recommendation. 0 patients received an antidepressant alone, as this was used in conjunction with at least one additional treatment option. Therefore, this specific treatment recommendation was excluded from this figure, as this was included as part of the 12.7% demonstrated on this bar graph. This project set out to establish an answer to the following PICO question. For patients ages 18 to 89 years old who presented for routine primary care visits that were depression diagnosis and treatment naive, was standardizing the use of the 2-step patient health questionnaire depression screening protocol compared to not using a standardized screening method more effective at identifying depressive symptoms, thus increasing the number of patients diagnosed and the frequency of initiated treatments? As you recall, the pre-intervention EMR report indicated that only 13 charts contained documentation of a prior depression screening protocol having been performed. I'm very proud to say that this project successfully identified 75 patients with no previously reported depressive symptoms who were positively screened with this protocol and required a new diagnosis and treatment for depression. Additionally, these findings were similar to those of other relevant studies. Most of the available and current literature fully supported the use of this 2-step protocol due to the accuracy of the PHQ-2 at detecting depressive symptoms without the need for a full screening with the PHQ-9. Furthermore, this protocol proved to be advantageous to busy clinical workflow, as those who screened negatively with the PHQ-2 did not require additional screening with the PHQ-9. And lastly, we used the most appropriate cutoff scores in order to fully implement this project. So as you recall, I established the PHQ-2 cutoff score of 3 and the PHQ-9 cutoff score of 9. And based on the current literature, it fully supports these cutoff scores, as they provide the best balance of sensitivity and specificity while reducing the likelihood of false positive results. This study had several strengths. First, it illuminated the prevalence of depression. Next, we were able to officially establish this depression screening protocol at this facility. We also improved the patient-provider mental health communication, and there is great sustainability of this product as well. Unfortunately, there were also some limitations, the first of which being that not all patients were screened. Only 50.1% were actually screened. Therefore, 49.9% of them were left unscreened, which means these patients may still be suffering from unrecognized depressive symptoms. Additionally, the generalizability may be limited when compared to studies that were conducted in rural or urban areas, those that predominantly consist of minority races, or facilities in areas that suffer from poverty level income with limited access to health care. There are some methods to improve the outcomes in the future, and the first of which being establish a policy to schedule patients for screenings. So for this project, if the screenings were not performed during the regularly scheduled appointment, the provider was required to alert the clerical staff directly via verbal communication of the need to schedule another visit for the screening. However, if the provider schedules the patient themselves, this could increase the likelihood that the patient would actually return for that next visit. And I feel that if the provider speaks directly with the patient about the importance of returning for another visit to be screened, the patient will likely be more amenable to this plan. They will agree to be scheduled and actually keep this appointment. This project has several implications for practice and future research. First, we must continue to perform screenings using this protocol, and I would also like to screen all patients regardless of the type of appointment for which they are scheduled. There's also implications for healthcare policy. We must increase funding and awareness of available resources in order to improve access to mental health care. These factors could serve as a primary support system that has the potential to improve the health and well-being of the patient, their family, and the community at large. And lastly, there are implications for quality and safety. We must routinely evaluate a facility's infrastructure and staff awareness regarding depression. So by properly educating staff and providers on the importance of adhering to established protocols and keeping pace with evidence-based practice, organizations will safely and effectively provide adequate and complete patient care. In conclusion, depression is a pervasive issue amongst adult patients. Screenings help to promote mental health communication and identify unreported depressive symptoms. And this project significantly improved the frequency of depression screenings performed at this facility. Therefore, continued screenings with use of this two-step protocol on every adult patient that presents to this facility is the primary recommendation based on this study's findings. By doing so, this protocol will promote the continual improvement of the overall health and well-being and the quality of life amid the patient population at this facility. The next slides are my list of references. This will conclude the presentation of my scholarly project. I hope you enjoyed it. Thank you so much for watching.